Hi, everyone. Thanks for having me on. Thank you for the great introduction, and very pleased to be part of this esteemed meeting. The panelists are great, and it's a privilege to be here. So, if there's nothing else, Sophie, I'll make a start.
Sounds great.
Okay, so I'd like to share my screen. Sophie, are we seeing this screen of mine?
Yes, we are. It looks great.
Perfect, thank you. Um, I would like to talk about venous ulcers, and they're a big burden in our community, and I think most GPs will have at least a small handful of patients, if not more, with complex ulcers and chronic wounds. And I just want to give an insight into the vascular component of that, specifically focusing on venous reflux. So I'll spend a bit of time talking about who we are as a group, and also then getting into the actual topic in depth. Yarra Vasculars is basically a group of surgeons, specialists, and allied health based in Melbourne at the moment, and hopefully in the future looking to offer our services interstate as well. We have an institute model of care, and it seems to be somewhat unique, at least in Victoria anyway, for having a vascular institute or group model. We provide 24/7 care, and we have multiple different aspects to our service, from vascular surgeons to a physician, a wound specialist, podiatry, wound nursing, and patients, and sonography. Of course, patients' primary carer, such as general practitioners, are very much a part of our multidisciplinary service. And in fact, we have a multidisciplinary meeting every Monday morning at 7:30, where we invite routinely the patient's GP to participate in the discussion. And we all kind of work at different public and private hospitals across the metro and regional part of Victoria. And this is just a brief glimpse into who we are. And without further ado, we'll get into the actual topic at hand today. And I thought I'd start by just talking a little bit about the wound classification and etiology. So really, we're looking at chronic wounds, which are different to acute based on their duration or their presence. And we can see here that the types of chronic wounds are mainly venous, arterial, neuropathic, infection, and pressure. And actually, most of these have a vascular component. And so therefore, this is why I suppose we as vascular surgeons are passionate about this, and we love treating chronic wounds because we can make such a big impact. The kind of actual reason that chronic wounds are important to distinguish from acute wounds is because because of their difference in all aspects of management and investigation. So what we have as chronic wounds are etiologies, which are usually systemic and local, rather than just local with acute wounds. They're generally multiple factors involved with chronic wounds. Their complexity is high, requiring multidisciplinary input. Investigation is usually thorough, and intervention is usually both systemic and local. So usually you won't heal the chronic wound just by intervening on the wound itself. There's usually another systemic factor, whether that be diabetes, blocked arteries, incompetent veins, whatever that is. The relapse risk is high with chronic wounds, and thorough surveillance is required. So it's a very different paradigm to treating acute wounds. So venous reflux, kind of zooming in on this as a cause of chronic wounds, is a very common disease. Venous reflux affects up to 60% of the adult population, and more so in females than males. It all comes down to venous hypertension, and that is essentially the driving factor behind all of the manifestations or clinical manifestations of the condition. In terms of why you get venous hypertension, well, that's usually singularly due to valve dysfunction. So, and valve dysfunction in turn is usually due to a genetic predisposition. So risk factors for valve dysfunction can be obesity, pregnancy, but by far the biggest thing that we see is genetics. And that's why, one person who works for 30 years standing on concrete gets veins, varicose veins, and the other one doesn't. It's not so much due to the occupation or the standing, but it is the genetic valve dysfunction. So we generally consider these occupational type things more as a exacerbation fact rather than a cause itself for vascular insufficiency or venous insufficiency. So you'd all have seen something like this before, which is our CAP classification, which is pretty much an international based system for classifying the stages of venous insufficiency. Starting with stage 1, which is spider veins, stage 2, which is lumpy varicose veins, stage 3, which is leg swelling, and then more into the advanced stages when you get to 4, 5, and 6, which are skin changes, and then healed and active venous ulcers. So really, the more advanced conditions or advanced venous reflux is from stage 4 onwards, and this is also what we classify as complicated varicose veins. So skin changes can be hemosiderin deposition, lipodermatosclerosis, eczema, psoriasis, and then once you get skin changes, then we know that you're on a track towards developing an ulcer. So that is an automatic risk factor. Once you start getting skin changes, A, they're irreversible, and B, usually in the future, those patients left untreated will go on to develop ulceration. Now, thrombophlebitis is another recognized complication of venous reflux, as is bleeding. And no doubt as those who are practicing and seeing patients would have come across these. I think it's worth spending a little time on thrombophlebitis, superficial thrombophlebitis, because it is a very kind of popular topic or question that I get asked about. And really, there's no kind of solid, good guideline, at least in Australia. There is the American College of Chest Physicians who have a guideline, but I thought I'd present a small algorithm that I use to advise and advise other practitioners and in my own practice. So essentially, if a patient has superficial thrombophlebitis, the first thing is you want to check that they don't have a DVT. So usually a good sonographer should automatically check the deep veins if there's a suspicion of, or if there's a finding of thrombophlebitis in a superficial vein. So if the length of that thrombophlebitis in the superficial vein, which is usually one of the saphenous veins or its tributaries, if it's more than 5 centimeters in length, then you should consider treating with Clexane. Now, Clexane, 40 subcut is the standard, but there has been a more recent trial, which is the SURPRISE trial from 2017, which actually suggests rivaroxaban to be non-inferior. So that's a viable alternative, and one that I generally use because it doesn't require, an injection every day. It's just a tablet, 10 milligrams. So you could substitute the Clexane for a 10 milligram dose of daily rivaroxaban. If it's within 3 centimeters of the junction, I generally treat that as a DVT. And if in those patients, for any reason, anticoagulation is contraindicated, then we would consider ligation of the junction, saphenofemoral or saphenopopliteal. It's extremely rare to have both a combination of clot 3 centimeters within the junction, as well as being contraindicated for anticoagulation. So it's not very common that we do that. For pregnant women, Clexane, if they get a superficial phlebitis, then we would recommend Clexane as the choice, and that should be used throughout the remainder of the pregnancy as well as 6 weeks afterwards. And if there is an association with an IV cannula, not the inferior vena cava there, sorry, IVC standing for cannula, then just remove the cannula and medication is generally not required. But in all cases of thrombophlebitis, you should repeat the ultrasound within 2 weeks to assess for progression and consider a vascular referral to collect correct underlying venous insufficiency, which is in 99% of the cases, well, in pretty much all cases, there will be underlying venous insufficiency as the cause if it's not traumatic. Compression, elevation, and non-steroidals are obviously also part of that regime, but that's just a quick algorithm for treatment of thrombophlebitis. And these are just some photos of various venous insufficiency stages. So this is more early stage 1, but this is getting into your skin changes. So you can see here on the top left that you've got hemosiderin staining, but the skin quality itself is not too bad. On the right, on the bottom left, sorry, you can see that there is quite marked hemosiderin staining with a thickening of the skin, as well as quite marked edema, and you're getting that picture in both the bottom pictures here of that inverted bottle, champagne bottle description. But what you're also seeing in this picture on the bottom left is quite a significant redness. Now, we do get referred a lot of patients with recurrent cellulitis or cellulitis not responsive to antibiotics, and with these types of legs. And what we find is in many cases, these patients actually have venous stasis dermatitis rather than cellulitis. And there is a significant kind of overlap in terms of symptoms. But just keep that in the back of your mind with patients who have cellulitis that is recurrent or non-responsive to antibiotics, whether it's actually a stasis type reaction. And this patient on the bottom right, you can see quite extensive venous eczema, which can be quite debilitating, quite irritating for the patient, having to scratch it, and thin, flaky psoriatic skin. So these are some pictures of venous ulcers, which I would normally get some interactive kind of input on, but in this case, I can just kind of go through and describe them. But we have here a very typical venous ulcer, and the features that make it so are that it's superficial, that the base is quite healthy and in fact granulating and pink, minimal slough, very superficial, and in the typical gaiter region or ankle region. And you can see the skin is quite poor quality, very dry, scaly, and some possibly elements of pigmentation there. This ulcer is a little bit different. So it is in a similar location, gaiter region, with the staining, and you can see multiple varices in that ankle region. But it is also very sluffy. It's not got that pink, healthy granulating base that the other venous ulcer had. The edges are a bit more marked and raised. And so this would be more of a mixed arterial and venous ulcer picture that we would look at and think that we'd want to investigate with some ABIs and possibly an arterial duplex, as well as the venous studies. And then there is also this element of abnormality here, which could just be a small, cutaneous hematoma or blood blister, or alternatively something a bit more sinister. And so biopsying in these situations is also quite a good idea. And this is a more typical finding of a healed venous ulcer or atrophy blanche. And you can see that you get this pale white skin where the ulcer used to be, with quite significant skin pigmentation around it. So differentials for venous insufficiency, swelling, heart failure, lymphedema, cellulitis. So that the swelling side of things can be multiple, and whenever patients come in with swelling and venous insufficiency, I always do counsel them on the other potential causes for swelling, as you can see there. But as far as pigmentation and eczema goes, dermatitis could be a differential to consider. And ulcers, of course, can have multiple different kind of etiologies, like we saw earlier. So malignancy, arterial, and neuropathic. So always keep these in the back of your mind when you're dealing with what we think are venous ulcers. Now, diagnosis is generally by ultrasound. Can be a challenging scan to perform, and what we look for in the ultrasound is flow reversal in the vein after a period of augmentation. So we basically use our hand to augment the calf, so compress the calf muscle. We see the blood travel up the leg in the vein, and then what we watch for is blood refluxing back down. And if it refluxes back down for more than half a second, that's pathological and suggests insufficient valves. So we generally, these kind of scans are done by vascular sonographers. So I should say they are done in the community by general ultrasound labs, but we also do kind of get a lot more information from vascular sonographers. So most of the time, if a patient's referred, they will get a scan like this from our imaging our sonographers. And really what they give us here is a more detailed map and the worksheet, so we can actually map out what targets there are for treatment, and whether there's any perforating veins and whatnot. So it's quite a detailed study, and this is kind of the map that we use. And you can see here, it talks about everything from the incompetence of the junctions, to incompetent thigh perforators, incompetent calf perforators, deep venous insufficiency. So they actually augment and check the deep veins as well. And they also check for DVT. So it's quite an involved study. In terms of when to refer, so if a patient has complications of their venous insufficiency, then we generally recommend a referral to a vascular surgeon. Those would be skin changes, which indicating quite advanced venous insufficiency and risk of future ulceration, thrombophlebitis and bleeding, obviously as recognized complications of venous insufficiency, and ulcers, either active or healed ulcers. In terms of referring other things, so patient pain, and so we see obviously a lot of patients with venous insufficiency who don't have complications, but they have quite significant debilitation from a symptom point of view, or they really don't like the appearance, and you know, they want to be able to live their lives the way they want. And so we do obviously treat and see a lot of patients who have quite significant pain, swelling, you know, teachers, especially people who have a job which requires them to stand for quite a long time, can have quite a significant lifestyle improvement from having their veins treated. And yet we also treat patients who have cosmetic and unsightly veins. So generally at that stage, when it's pain, swelling, or unsightly, then it's a patient preference. And that's the conversation we have with our patient is, you know, this is not a dangerous condition. It's at a stage where you can choose really whether you want to treat it or not, or go with conservative or active or interventional treatment. Management of venous reflux. So there's a whole, you know, armamentarium that we have in terms of everything from microsclerotherapy to open ligation and stripping. I must say open ligation and stripping is now very much reserved for patients who are unsuitable anatomically for the minimally invasive treatments. So most of our patients are being treated with endovenous therapies. Now there's a few different types. There's laser ablation, radiofrequency ablation, and cyanoacrylate glue ablation, and they all have very similar results. Laser was the first one that came out, and in many ways it's now kind of obsolete, because the endovenous ablation is a bit less tedious to perform because there's no laser involved. So that uses microvibrations to generate heat. So laser and radiofrequency are both thermal ablation techniques, and cyanoacrylate glue is the latest one, and we're performing that. It's a bit more pricey and expensive, without much difference in terms of gain from a result point of view, but there is a place for that in patients who are intolerant of local anesthetic, because that one doesn't require much in the way of local anesthetic. There are some videos here which, if anyone's interested, please contact Telecare, and I can pass this slide on with some videos on those procedures, but I don't want to dwell too much on the technicalities of the procedure. And so with that, I'll conclude, and just to summarize, we basically talked today about chronic vascular wounds and zoomed in on the venous aspects, and we then focused on venous reflux. So when we talk about venous reflux, it is different to chronic venous obstruction, or sometimes colloquially called chronic DVT, which can also cause venous ulcers and wounds, but we've kind of really focused on the venous reflux, which is the most common aspect of venous ulcers. So I hope that was insightful, and thank you again for the opportunity to present. And I'll hand over back to Sophie to moderate if there are any questions.
Thanks so much, Raj. We do have one or two questions or a comment. One of them is, I'm enjoying how practical this venous disease presentation is, which is lovely. And then we've got one, are endovenous therapy covered by Medicare?
Yes, very good question. So endovenous therapy. So I can speak for our setting in Victoria. So I work at a public hospital, which is Northern Health, and I think it would be similar for most of the public institutions. we do have limitations on what we can treat in the public hospital. So in public, we generally are limited to treating complicated varicose veins, so either clotting, bleeding episodes, or venous ulcers, basically, or very advanced skin changes. So for those patients, definitely a referral through the public system, and they will be entitled to go onto the wait list in the public system. In terms of treating patients through the rooms, I can kind of give you an indication as to what. So our basically, it depends on what procedure is required, but the range is essentially from, for having one leg treated for a microsclerotherapy cosmetic treatment is about $500, and I think it's about $590, and there's a $90 Medicare rebate. And then in terms of the bigger treatments outside of the public system, so endovenous ablation and sclerotherapy, for two legs, for one leg is about $2,500, and two legs is about $3,500. And so that's out of pocket. So actually the patients end up paying about $5,000, and they get about a $1,500 to $2,000 Medicare rebate from Medicare. And so then the out of pocket is about $3,000 to $3,500, and that kind of covers everything from their follow up to the stockings to. But that's just a brief insight as to what we charge, and so we generally offer patients, and then there are discounts for basically we will we assess our patients situation and means, and if they have a genuine problem and they don't meet the public criteria and they're really in financial need, we'll make it work for them one way or the other. So so we kind of have that approach, but to give you a rough idea is really from the very basic treatment, $500 all the way up to having both legs fully treated in all respects for more advanced disease, up to $3,500 out of pocket.
Great. Thank you so much, Raj. And I've got another question here. Is it covered by private health funds if someone has comprehensive cover?
Yeah, it's a good question as well. So yes, the venous treatments, so basically injection sclerotherapy, anything that can be really performed in the rooms is kind of not really covered by private health insurance. So for example, in our practice, so even the most complex treatments, with the endovenous therapies, when I say complex, they're all kind of needle hole type treatments, but even the bigger ones, we perform basically everything except open surgery in the rooms now. So whenever, for example, I take a patient to a private hospital to do a minimally invasive venous treatment, we get a form called a Type C form, which means that we have to actually justify why that patient needed a hospital admission to treat. So the short answer is the hospitals are discouraging us from taking patients. And so also the fact is, the item number is covered, and we will take patients to the private hospitals if they choose. Unfortunately, it's quite expensive actually, taking into account the costs involved. So for a private hospital admission, generally the patient has to pay for a surgical gap, an anesthetic gap, as well as for the sonographer, because the private hospitals don't have vascular sonographers. So then we need to pay for a vascular sonographer to attend the case, because they are an important part of the case. And then there's also the excess. So for us, generally, if we quote for a patient to go to a private hospital to have their veins done, I need to justify that there's a reason, and usually that's intravenous sedation, or the patient has a needle phobia. But then they end up actually paying about $1,000 more out of pocket when you add up all the other excesses and surgeon, sonographer, and anesthetic fees involved. So yeah, the rooms actually, most of our private patients, insured patients, have their treatments done through the rooms because it's more cost effective and they're getting exactly the same product. And it's hopefully keeping premiums down for everyone by avoiding expensive private hospital fees for those things. So generally we offer both to patients, and the ones that really benefit from having it in a private hospital and are the ones that are truly needle phobic. And most patients tolerate the procedure very well in the rooms. And I can't remember the last time I took someone to the hospital because they were needle phobic. But yeah, the short answer is it's covered it's probably going to cost the patient more out of pocket in the private hospital, and probably going to put everyone's premiums up by doing a minimalistic procedure in the private hospital.
Great. Thank you so much, Raj. Did anybody else have any questions before we wrap up? Or Raj, did you have any other comments that you'd like to make?
No, thank you again very much for the opportunity. And yeah, by all means, if there's anything further anyone wants to know about, the logistics of treatments or whatever, they are more than welcome to contact us and our practice manager. And yeah, we'd be very happy to help. But yeah, absolutely. I hope it's been useful.